Hello and welcome to the fifth and last evening of the EAO Digital Days. My name is Gerrit Heikop and I'm joined again by Sandy Heribert and the president of the EAO, Henning Schniepaker. Good evening, Henning.
Good evening, Gerrit. Good evening,
Sandy.
Sandy.
To you both.
Good evening, everybody out there. And thank you very much again for joining us here for the last and fifth day of the EAO Digital Days. It's been a fabulous week and we have been overwhelmed with the feedback we receive from all over the world.
Thank you very much. So thanks to those who are logging in for the first time. Let me remind you that all the videos are available for everyone on the platform until October 11th. After that, they will only be reserved for the EAO members on the online library. So make sure that you join the association if you're not already a member in order to benefit from such high quality content throughout the year. Tonight, you have prepared something very special for our viewers, Henning.
Yes, of course, you cannot talk about implant dentistry these days without covering issues related to the COVID-19 and how it has affected our daily work. The EAO has already organized an online live session on this topic already as early as April this year. That was hosted by Michael Payer from Austria with contributions from Professor Man Ji and Dr. Nikos Mateos from China. This was extremely helpful for those colleagues in those countries where the pandemic has not reached its peak yet. As it progressed, we decided to devote a full evening on the digital days on this topic, and we hope that you will find it helpful and educative.
Now, with no further ado, let's welcome our speakers for tonight.
Dear ladies and gentlemen, dear colleagues, I'd like to welcome you most cordially to the EAO special edition on COVID-19. Being a dentist, we are thought to be among the medical professions with highest risk for infection during our daily work. I suppose that many of you don't know that the EAO is having a special interest in COVID-19, and now my co-chair, Björn Klinge, is going to tell you more about this.
First, I would like to say that there are some people who don't quite agree that this is a topic for EAO and a EAO Congress about the COVID-19. But if you think a little bit more of it, this is something that concerns all of us. And therefore, the board decided that it would be very important to bring in the dental environment in terms of health perspective for those who work there. And Catherine and myself were given the opportunity to bring this live and contact persons in the European Union that could add to this information. And this year, as a gesture of solidarity, the EAO donated 50,000 euro to the European Commission for research for a vaccine against COVID-19. And the organization, the organisms who works closely with this is called Coalition for Epidemic Preparedness and Innovation. And it is coordinating funding and the whole procedure and the development of these 9 vaccines around the world.
It is also my big pleasure to introduce and to welcome excellent speakers from various countries and also from various specialities. I'd like to introduce our first speaker, Jörg Timm. Since 2013, he is director and professor at the Institute for Biology at the University Hospital in Düsseldorf. And currently, he's also the Vice Dean for research at the same medical faculty. Since this year, he is head of the National German Reference Center for Hepatitis C viruses, and currently he is actively involved in various studies on coronavirus disease 2019 and the SARS coronavirus 2. So please, Jörg Timm, we're looking forward to your presentation.
Yeah, I would like to thank the organizers for the kind invitation, and I was asked to present something about SARS coronavirus and what makes it so special. And I think you can already appreciate that it's somehow special these times because I'm giving this presentation here from a studio. And I think this is also probably unique for your conference that you do this in this new setting and format. Just to recapitulate what happened so far, so the beginning of COVID-19, you probably all know or all remember. It started in the end of 2019 when there was a cluster of pneumonia in Wuhan in China. And it was quite clear that it was an infectious disease that was spreading, but it was not diagnosed. So there was apparently a new virus that was going around. And it took only a couple of days to really identify this virus as a novel coronavirus. This cluster was reported to the local WHO organization. And when it was clear that the virus also spread outside Wuhan to other cities in China, but also outside China, the WHO at the end of January declared this outbreak a public health emergency of an international concern, giving the WHO also some tools to organize trafficking and things like that. And in February, we came to the final name of this new disease. So COVID-19 is the name of the disease, and the virus that is causing it is SARS coronavirus type 2. And from the name, you can already see that there's also a type 1, which was the large outbreak we had in 2003 mainly. That was also a severe acute respiratory syndrome disease, but that was not as large, this outbreak. And then in March, when it was really clear that there was a global situation, the WHO declared this outbreak a pandemic. What is the situation now in Europe? And I think you remember that we had really a spread of this disease mainly in March and April, and then in most countries in Europe, the situation resolved. We had different lockdown measures in most countries, and this really helped to prevent spreading. And during the summer, it was actually overall a very quiet situation. There was not much in infectious disease in terms of COVID-19. But since August, late July, let's say, we have now really increasing numbers again. And you can see here from this graph of the cases. So these are all cases that have been truly detected by PCR. So the really true cases, that the numbers are really increasing at the moment. And this is, of course, of great concern. We have to put into this calculation, these are always the case numbers, that also the diagnostics have improved and are more widely available. So, of course, we detect more cases because we do more diagnostics. That's a good thing, because we really want to have a very good overview what's going on in terms of this disease. So what kind of virus is this? One thing that is important, it's an envelope virus, and that's not only important for a virologist, that's also important for the hygiene measures, because it's very easy to inactivate. So very basic disinfectants are really safe. Even soap is safe to inactivate this virus. So it's not very stable. The main transmission route are respiratory droplets, but also that's something that over the past months became more clear. Aerosols are really also important, and that makes it a bit more difficult than many other viruses, where really these respiratory droplets are the main infectious route. Aerosols are something that are more complex to prevent. We have a basic reproduction rate. This is a number, how many secondary cases are produced by one infectious person. So we have here a reproduction rate of 2.4, around 3, let's say. So that means one person infects 3 other persons if you do not take any prevention measures. And this is, let's say, in the mid-range. So there are other viruses like measles that are a reproduction rate of 10, let's say, so much higher. But influenza, for example, it's probably around 2, so that's lower. There's no licensed vaccine yet. You all know that this is really something that we are all waiting for. And there's no established really licensed therapy. There are some concepts, but most of them are not really licensed yet. at least not in terms of antiviral therapy. I mean, of course, you can treat symptoms and also the inflammatory response that's coming with the disease. So what are the first symptoms? It's a respiratory disease, and that's really not very different from any other respiratory disease. That's the problem. So you cannot take really simply the symptoms and make a case that this is probably COVID-19. So fever, cough, fatigue, shortness of breath, this is something that you have with every respiratory disease. So that does not, unfortunately, make COVID special. So therefore, you cannot really take the symptoms and make the diagnostics. An important question is, what is the fatality rate really? And you may think this is a very simple question. You just see how many patients are sick and then check how many patients really get severe disease. And this is something that is of course done. So when you look at the cases, and these are only in the public databases, cases that are really tested positive. And from this you can make the calculations. You can see how many of those have severe disease, how many of those are treated on an intensive care unit, and how many of those die. But the big problem then is, what is this number, namely the true infection number? And this is much more difficult because obviously this is the number that you do not have in this calculation. And it really depends strongly on the test intensity, how close you get here really to these exact numbers. That's very important to understand when you compare also case fatality rates across different countries. So these are the numbers here that we are using in Germany. And this is from the official health authorization here, but I'm sure this is basically the same numbers that are used in other countries and as well. So we think that the time where you can spread the virus to other patients or people is around 10 days. So that means before you get symptoms, 2 days you are already infectious for other people. That's the really difficult period of time, because you are pre-symptomatic, you do not feel sick, but you also already start to spread the virus. Then you have this phase where you're symptomatic. Not everybody does this. So around 80% only develop any symptoms. So that means 20% do not develop any symptoms. But the symptomatic phase typically lasts about 9 days. And most of them really recover without any difficulties. So 95% are really not very sick. So they have just a mild disease, respiratory disease, like a common cold. But 5%, a little bit less probably, they are hospitalized. So they have to go to the hospital because they are severely ill. And of those, 25% need to go to the intensive care unit with different outcomes. So only 50% really recover if they are on the ICU. So that is a pretty high number also compared to influenza. So you have then in the end, or overall mortality rate caused by this disease around 0.2, 0.3%. Here we look at the case fatality rate in selected countries. And I just want to make the point that there are huge differences between different countries, because that's probably the main reason, because the testing strategy was very different. In Germany, we started to test very early and we had overall a low case fatality rates, but that's because we found the cases in probably better than many other countries. And you can also see that it's fluctuating over time. And this is partly because the testing strategies have been changed in these countries. But another reason is, of course, also that the measures that were taken, the space on the ICU was then in the summertime available again. And so the death rates were declining, fortunately. Okay, so what is then really different between COVID-19 and other respiratory diseases? And what you can see here is the frequency of severely ill patients on an ICU caused by the respiratory disease during a regular flu season and now at the moment during COVID-19. And I think what you can see is really the main difference is that the younger age that is also typically affected in a regular flu season, that's currently not affected at all during COVID-19. And this is highly reproducible, so it's really not the young people that are getting severely ill at the moment. So here are case fatality rates according to age. And as you can see, so these are different countries, but it's basically the same picture in every country. Young people, kids, they are not really getting very sick and they do not die from this disease. It's really the older people that die. And this is a very typical characteristic of this disease here at the moment. But there are other risk factors, of course. These are typical risk factors, after all, that we also know from the flu, for example. So if you have cardiovascular disease, diabetes, at least diabetes, that is not really under very good control. If you have any other chronic respiratory disease, things like this, you have a higher fatality rate, a higher likelihood of dying. Okay, so what are the diagnostics at the moment? So we have basically 3 different ways to diagnose it. What is mainly done is we detect viral RNA. I will show you in a minute. We have, that's a novel player in the game, an antigen test that might really help for control of the pandemic, and we have antibodies. When you do a test, you need a proper material, and what is considered the best material at the moment is still the nasopharyngeal swab. So basically a swab, and I put a picture here, that is taken through the nose at the back of the throat. You can also test other respiratory material, but this is still considered by most officials the one material that should be tested for the first diagnosis. And then you have different ways how to test it. Typically at the moment, most labs use commercial PCRs that are used for high throughput testing. So large equipment with a big advantage that you have high throughput and low costs typically, with the disadvantages that it takes time and it is really complex in handling. So you of course need a professional lab for that. And there are new tests, even for molecular testing, now on the market that have short turnaround time, that are easy to handle. In fact, most people can do it, maybe not everybody. But what is important, this is really not high throughput. But technically, these tests can be done as point-of-care testing. You could also put this in an outpatient setting and have then test results after 30 minutes. A very important question of the past weeks or months was really if it always has to be this nasopharyngeal swab, or if also saliva is also good for testing. And there are now really good data out there that saliva is probably as good as the swab, which makes it much easier because you do not need professionals really to do the testing, to take the material. So this is something that might change in the future. So the second thing I would talk about is an antigen test, and that might be really, in this outpatient setting, be very interesting. So these are really very simple to use tests, even though still they are only recommended or licensed for professionals. So you cannot use it as let's say, a test in your private household. But according to the manufacturers, the sensitivity and specificity of these tests are good. I put here a question mark, because I don't think in real life they are as good as it looks like they are here. But the big advantage here, they are easy to handle. And what we have to keep in mind is that they still have a lower sensitivity. So they're not as good as the PCR, but they're probably good enough to really identify those people that are infectious for others. So when you look at data where you basically check how often can you take virus and put it in culture and as a measure of infectivity, at a certain threshold you will not be able, if the virus is very low, the virus concentration is very low, you will not be able to grow the virus in culture. So there's not any infectious virus left basically. And this is probably the threshold where the antigen test really has the cutoff. And that's very interesting then, because if this is really true, then you can use this antigen test, and this takes like 20 minutes for €5, and you can identify those that are infectious. So in many settings, that might really be a game changer here for the management in the pandemic. Okay, and finally, I would just briefly mention that there are also antibodies, but I would like to make the point that this takes like 10 days normally before antibodies develop. So for the diagnostics of an acute disease, that is really not very efficient. It's more interesting if these antibodies really correspond to immunity in the end. Some final thoughts about how to prevent COVID-19. And there are some studies now on oral rinses that you can use for disinfection of the oral cavity. And there's one study that really nicely showed that there are a few different products on the market. So they basically took the products from the shelf of supermarkets and drugstores, and not all of these products, but there are a few that are particularly strong in bringing down the virus concentration, so the viral infectivity. It's not clear if this is really then also a mean for preventing viral transmission in this setting, but it's a very easy way at least to get down the viral concentration and the viral infectivity in the oral cavity, and that might help if you are working in this area. Then, of course, you all know that physical distance is really helping. I think you have learned this over the past months, just to show the data that this is something that is really, there's very strong evidence that this is something that we should do. If you have a distance of more than 2 meters, basically, there's no transmission left for this virus, also for other viruses. And finally, there's always this discussion, is it really necessary to wear face masks? And I think probably the experimental data is very solid now, because there are really different studies, and this is one of them, where people with an infectious disease, so this is a coronavirus, although it was not SARS corona, it was one of the endemic coronaviruses. So the patient with this disease was put into a room, and basically everything that was that he breathed into the air was filtered, and it was checked if virus was in there. And what you can see here is when you look at the droplets, if you do not wear any face masks, there are still some droplets spread out. If you do wear a face mask, basically there is no droplets that contain any virus anymore. So that really shows that the face mask is helping in this setting. And it's actually the same for aerosols. So this is always, you always have to see the face mask in a way that the person who is wearing the face mask is protecting the others. So you are not protecting yourself by wearing a face mask. But with this data, I think it's very clear that face masks are a good measure for prevention. And also in meta-analysis, it came through this data. So face masks can decrease the rate of transmission. Different studies now have shown this, not only for other coronavirus, but also now for SARS coronavirus. So it's a very easy way, and it's a very effective way to prevent transmission. Okay, so this is the final slide. So what everyone can do, I do not have to recapitulate, I think, the rules of hygiene here. I think we all know them by now, but I think this is really the most important thing that you also need to consider in every setting that you are working in. I hope with a vaccine that hopefully will be available next year, we will get through this pandemic, and I hope you all be safe.
Dear Jörg Timm, I'd like to thank you for your excellent, interesting presentation on the question, what makes coronavirus so special? I have some questions for you, and I'd like to start with the first question. I'm wondering, what is the role of antigen tests, and will they become widely used in dentistry in the upcoming season?
I think they have the ability to really be very important for the management of the pandemic, but that strongly depends on the sensitivity in the end. So it is very important if you really identify those that are infectious. And if this is the case, and I'm at the moment fairly optimistic, then this would really help in various settings, but obviously also here in this in the setting of the practices. Of course, we have to see the whole world is probably looking for these tests, if these tests are really available in every country, in every setting. I could imagine that there's also then a shortage of the material. The test capacity will be, of course, important here. But technically, I would be optimistic that this will be a very helpful tool now.
Will antigen tests replace our PCR swabs because they are more specific in detecting patients with a virus load above a certain threshold, or will both concepts still be used?
I think it will not really be a substitute for the PCR testing. I think in the hospital we will still require PCR testing because we really want to know when the patient is coming in, what is the cause of the disease, and therefore we need the most sensitive tests. I think it's a very different scenario outside a hospital, and there it might even be a benefit that you do not detect really every low-level virus. That might even be sometimes good to focus on those patients that really are able to spread the virus. But I think time is really an important issue. That's the problem at the moment when you do widespread testing, mass testing, that it takes a couple of days sometimes even if for the turnaround that the test results are coming back. And in terms of prevention measures, that's obviously then a very difficult situation because it might be too late if you have the positive result then.
Now I'd like to introduce our next pair of speakers, James Allison and Richard Holliday from Newcastle University. And James is currently a clinical fellow in oral surgery, whereas Richard Holliday is an NIHR clinical lecturer in restorative dentistry, and both of them are currently co-leading a research project on dental aerosols. So please, James and Richard, the stage is yours.
Hi there, my name is Richard Holliday and I'm presenting today with James Allison. We're both from Newcastle University's School of Dental Sciences. We're presenting on the topic of dental aerosols today, and this is a topic that our research group has conducted a series of studies on over the last 6 months. This is only a very short presentation. It just gives us an opportunity to talk through some of our main findings. There is much more information available in our published papers, particularly with regards to the methodology, and I would encourage you to look at these. You'll notice that there is a QR code on this slide and throughout the presentation. And if you take a picture of this, it will take you to links of all our papers so you can read them at your leisure.
Okay, so we're going to talk a bit about our methods first of all. So we used a fluorescent dye called fluorescent, and in 2 different sets of experiments we placed this dye into the irrigation reservoirs of the handpiece, or an ultrasonic scaler, or a 3-in-1 spray. And in a second model we used clean water in the instruments, and we instilled fluorescent dye into the mouth of the mannequin to more realistically simulate saliva flow. We carried out our procedures in 2 settings. The first image on the left of the screen, panel A, we can see a schematic of the large teaching laboratory that we used with mannequins, and we set up an 8-meter diameter rig around this mannequin, and this had 8 4-meter long rigid arms going out around the mannequin to allow us to support platforms, to place filter papers on, and these were spaced every ½ meter. In another series of experiments, we conducted procedures on an open plan dental clinic, and this used procedures in Bay 19 on this image, which is indicated by the red star, and we collected samples from the bay itself where the procedures were performed, as well as in immediately adjacent and in distant bays. So that allowed us to generate a large number of these filter paper samples, which were 3-centimeter diameter filter papers, and this collected the fluorescent contamination. We analysed these using 2 methods. The first was fluorescence photography, where we took some standardised photographs of the samples, and then used some image analysis software to measure the total surface area of fluorescent contamination. The second technique we used, which was slightly more sensitive, was called spectrofluorometry, and we eluted or dissolved fluorescent from the filter paper samples and then read the concentration of fluorescent using a plate reader. So just to look at some of our results briefly, looking at splatter specifically, we felt that our fluorescence photography technique measured mainly splatter, and we can see in this image, this is a heat map which shows contamination across the rig out to 2.5 meters, and the darker blue areas show heavy contamination with the lighter areas lighter areas of contamination. And we can see with this high-speed air turbine crown preparation on an anterior tooth that contamination is mainly opposite this right-handed operator and down the length of the patient, and this was with dental suction at medium volume. We can also see here some samples from the operator's personal protective equipment, and we found that on the open clinic most of the contamination stayed within the bay where the procedure was performed itself in terms of splatter. This image now shows our spectrofluorometry, more sensitive analysis technique, and this demonstrates where aerosol from the procedure settles out. This is again a anterior crown preparation with a high-speed air turbine, this time without suction, and we're showing here where the water spray goes with fluorescent in the handpiece irrigation system. We can see that this mainly goes opposite the operator again and down the length of the patient and goes out to at least 4 meters in this experiment. We performed a wide range of procedures, and these are more fully reported in our papers that you can reach using the QR code. But of particular relevance here is a series of experiments we did using a speed increasing handpiece to perform a crown preparation at the front of the mouth. And on the left image on the screen, this used a water jet spray coolant, and this is more akin to what you might find with a surgical handpiece, and that's compared to, on the right heat map, a more conventional mist type coolant spray that you might see on a high-speed air turbine handpiece. And we can see here that with the jet spray, more akin to a surgical handpiece, actually we're seeing mostly localized contamination, not much beyond 1.5 meters. And with the conventional mist spray on the right, we're seeing more widespread contamination. So we think this kind of setup is probably low risk for aerosol generation.
Now let's look at the open plan clinic. So in this figure you can see a plan of the clinic with a heat map overlaid. This particular experiment was using our model where the fluorescent dye is in the handpiece. This was of a crown preparation of the upper right central incisor with a duration of around 10 minutes. We had a nurse operating medium volume suction. The main points to highlight are that the majority of the contamination was within the bay itself, but there was distant spread, and this was mainly on the left-hand side of the screen. It's important to highlight that this model really is demonstrating where the water spray is going from the instruments, and not necessarily where biological contamination that's picked up from the mouth is going. In this next slide, you can see a more biologically relevant model. Here we have the fluorescent dye in the mouth only, and clean water running through the handpiece. You can still see there's a moderate amount of contamination within the bay itself, but we were particularly interested in distant bays, so in those bays 5 meters away. In these bays we either detected no contamination or we detected contamination at quite low levels. You can see here we're going to focus on 2 samples, the sample in bay 12 that was positive and the sample in bay 15 that was positive. We're able to do some calculations based on our experiments to determine how much of the contamination or the saliva from our mannequin was transported to these sites. And you can see that this was very low, and there was a very large dilution factor, potentially around 60 or 70,000 times diluted. That's equivalent to half a teaspoon of saliva mixed with a bathtub full of water. So next, let's look at dental suction. So first, here is the definition of low, medium and high volume suction based on NHS criteria. Next, we can see a bar chart showing the impact of medium volume suction in an open plan clinic. You can see here that it has a marked effect within the bay, but most notably is the effect it has in adjacent and distant bays, with almost 85% reduction in contamination. What's particularly interesting is that we found very little difference between the low level and medium level suction tested in this experiment. Finally, let's look at AerosolSettling. This is really important when considering when it is appropriate to clean an environment or a surgery after the aerosol generating procedure. The details of this bar chart aren't important. The main things are that the majority of this contamination happened within the first 10 minutes. After this time, we detected very, very low levels of contamination, and this really indicates that 10 minutes is an appropriate time to do environmental cleaning after an aerosol generating procedure, and this information will also indirectly feed into fallow time considerations. As with any scientific technique, there are limitations to our work. So for example, this is a passive experimental technique. The biological relevance also needs to be validated with biological models. And also we've used the worst case scenario in all of our experiments. So for example, we haven't used rubber dam, and further work is needed to look at the hopefully beneficial impact of this. Now let's look at our main findings. So we found that water spray can potentially travel large distances, and that suction reduces contamination and has its biggest effect at distant sites. We found there was very little difference between low and medium level suction. And in distant sites, so those sites that were more than 5 meters away, we either found no contamination or very diluted contamination, diluted around 60 or 70,000 times. We also found that little aerosol settles after a 10-minute period. Hopefully we've been able to demonstrate to you that we have developed a robust and reliable methodology and started to understand much more about dental aerosol. More work is needed, and our group is currently working on validating this methodology with biological models and understanding a wider range of procedures, conditions and mitigation factors. As we mentioned earlier, there is much more information on our work, particularly our methods and our interpretation of the data within our papers, and I would encourage you to look at them for more information. This work has involved a large group of people at Newcastle University, and I'd like to thank all of them for their time, and you can see that information on the screen. Finally, I'd like to thank our funders, without which this work would not be possible. Thank you.
Now I'd like to introduce our next speaker, Hans de Soet from the Netherlands. He is a biochemist and also received a PhD in oral microbiology, and for more than 40 years right now he is doing lectures and research in oral microbiology at ACTA in Amsterdam. Currently, he is involved in various research projects on infection control in dentistry and also involved in the development of a national guideline on this topic. So please, Hans, we are looking forward to your presentation.
Welcome to this presentation about the microbial challenges during this pandemic, with special emphasis to aerosol generating procedures in dentistry. I am Hans de Soet, Associate Professor in Oral Microbiology of ACTA. This model shows how microorganisms can cause an infectious disease. Several factors are needed to actually result in a disease. Important is that the microorganism is a pathogen, and the more virulent vectors a microorganism can use, the easier it can cause a disease. But also the transmission of the pathogen to the host is important. For instance, the type of treatment in the dental clinic where aerosols are being produced. Furthermore, the more frequent or longer exposure to a pathogen, the more risk there is for an infection. When all these risk factors are increased, then we may end up in the red part of the sphere, a true risk for infection. There are, however, several other factors involved in this risk. That is the inoculum size, how many infectious particles are transmitted, especially exposed to blood and saliva. This is important. But also the sensitivity of the host is an important issue. Older individuals are more vulnerable for many infectious diseases, especially when the port d'entrée, such as the oral cavity, the nose or the eyes are involved in the transmission route. And we can modify the transmission routes by taking the correct infection control measures. What we need to realize in the present pandemic is how many viral particles are needed to result in an actual disease. Up to now, we don't have a definite answer to this topic. Last June, a publication appeared presenting an animal experiment where it was shown that 1,000 plaque-forming units, possibly corresponding with 1,000 virus particles, was able to introduce a COVID-like disease in hamsters. This was not done, however, in a single infection. Therefore, we don't know exactly how to transfer these data to humans. but it's likely to assume that we need somewhere between 1,000 and 100,000 virus particles for humans to become infected. All right, keep that in mind. How many virus particles are actually spread by COVID-19 patients? In this slide, you see the mean numbers of virus particles isolated from COVID-19 positive humans. These are means from several studies where data on the viral load was published. The quantity per isolation differs greatly depending on the characteristics of the patient and state of the disease. But when bearing in mind the numbers of the previous slides, 1,000 particles needed to infect hamsters, this number is easily reached by a little bit of sputum of, let's say, 1 microliter of saliva, 1 drop of saliva from an infected patient. And it's good to realize that based on the size of this virus, we need to assume that 200 virus particles can easily fit into 1 aerosol droplet of 2 micrometers. What is an aerosol? This is shown on this slide from a paper of Y and Lee in 2016. They showed that the spread of large droplets has a fast deposition in the ballistic trajectory. Usually they fall within 1.5 meter after production, and when they reach the surface, however, they may produce fomites and may be responsible for infection through indirect contact. Medium droplets ranged between 5 and 100 micrometers may just reach 1.5 meter, dependent on the humidity of the air where they are produced. The smallest droplets, smaller than 5 micrometers, are named aerosols, and these can remain airborne for a long time, depending on the room temperature, the humidity in the room, and the airflow. In the dental field, there is, however, also artificial production of aerosols. Drilling with water flow, ultrasonic cleaning, and other devices produce droplets and aerosols that originate in the oral cavity, because there they mix with saliva. The moment the oral cavity is infected with pathogens, also these can be transmitted to the dental healthcare professional. But also when small aerosols are being produced, they can remain for a longer period of time in the treatment room and may contaminate the next patient, possibly through instruments. And of course, direct and indirect contact remains important source for cross-contamination in the dental clinic. We recently published data on the production of aerosols during the dental treatment and studied where bacteria are found during and after this treatment. We have chosen to study 3 critical locations around the patients to test the contamination level before, during, and after the treatment. For details, see the paper of Semery et al. 2020. The bacterial counts at the control sites were similar to those before and after the treatment. However, at the instrument location and at the chest location around the patients, about 100 times more bacteria were found compared to the controls. Moreover, after sequencing, it turned out that these bacteria were mostly from human origin, mostly common oral bacteria. How to prevent the transmission of the virus in the dental clinic? We should consider the risk for the patient as acceptably low, provided that the dental team is maintaining to the regular infection control measures, meaning personal protection equipment, cleaning and disinfection. The risk for the dental team, however, remains unknown, but may not be negligible, especially when the numbers of COVID-19 patients are rising as they are at this very moment. So some protective measures should be taken, and the National Institute for Occupational Safety and Health published a hierarchy of controls to be used to implement effective control solutions. This is the upside down pyramid of the hierarchy of measures to be taken in order to prevent transmission of pathogens, and we adapted this to the dental situation. Elimination of hazards means that COVID-19 patients do not enter the clinic and they can be reached by providing care on the distance or by performing care only in urgent situations. Also, proper triage is a good option. Ask for symptoms, measure the body temperature of the patient before they enter the clinic. This is, however, not always allowed due to privacy regulations in different countries. Moreover, a substantial number of pre- and asymptomatic patients cannot be determined in such way. The chance that they will visit the dental clinic is acceptably low when there is a low incidence of COVID-19 cases, but since they are rising now, it should be considered that these patients will visit the clinic and are actually sitting in your dental chair. In many protocols, rinsing of the oral cavity with disinfecting agents, such as hydrogen peroxide or iodine, have been included. Some even suggested using chlorhexidine, and the latter is not effective against this virus. Moreover, rinsing may provide a false feeling of safety. It only inhibits the virus particles that are actually present in the oral cavity at the moment of rinsing. More virus particles are present in the nose, in the throat, and in the salivary glands, and they will appear easily in the mouth during the dental treatment. So although pre-treatment rinsing is advised by many dental organizations, I am not convinced that this will really prevent transmission. It possibly will lower the risk, but not prevent it. The possibility for substitution is not an issue in dentistry, but engineering controls, they do. Using a rubber dam significantly will reduce the contamination of aerosols with infected saliva. But the rubber dam should fit perfectly, otherwise it has no sense. Disinfecting agents also fit in this category, but they are discussed earlier. Also, new aerosol suction devices are on the market last month. There are only a few that have been tested scientifically, and data suggests that this system can lower the risk of transmission, but it is too soon yet to be conclusive about these systems. Most important, however, is ventilation. In this slide, the transmission risk of SARS-1 as a proxy for the current pandemic has been used to calculate the risk for transmission in a dental setting. And we varied the viral load of the patient, so a high and a low viral load, the type of personal protection mask, no mask, a surgical mask, or an FFP2 mask. But most importantly, we varied the carbon dioxide level as a proxy for ventilation in the clinic. A high CO2 level in a dental clinic means that the ventilation is not good. In this slide, you may notice that the dark blue bars, indicating bad ventilation, are at least twice as high than when good ventilation is applied. So the transmission risk for the SARS virus can be lowered significantly by increasing the ventilation in a dental clinic. These mathematical data have been supported by recent measurements on aerosols and ventilation. And this is really an important issue for dentists. Note also that the effect of surgical masks, FFP2 or N95 masks, they will make a difference. FFP2 masks are much better in protecting for the transmission of the virus than the surgical masks. Administrative controls means that dental healthcare professional changes the way they work. That can be achieved by changing the route in the clinic, by taking care that incoming patients and outgoing patients are not within 1.5 meter distance from each other. The behavior of the patient, but also that of the dental healthcare professional, need to become adapted to this new situation, where we have to consider every patient as a possible infectious patient. Dental healthcare professional could also consider to refrain from aerosol generating procedures, but that's not always possible. Now back to the pyramid again, personal protective equipment. Of course, goggles should be used to protect the eyes, but face shields are even better because they protect against droplets and high velocity aerosols. Note that surgical face masks are for the protection of the patient and not for the dental healthcare professional. They have only a filtering capacity of about 90%, and we don't know whether this is enough when treating COVID-19 patients. So during this pandemic, respirators, FFP2 masks are advised to prevent the inhalation of aerosols that contain virus particles. We recently noticed, however, a great difference in advices between countries throughout Europe about the use of these masks. Possibly is this advice more based on the availability of the masks rather than on the safety. Note that FFP2 masks should fit perfectly, otherwise they don't filter enough. We cannot easily prevent the contamination of bacteria and viruses in our dental daily practice as a dentist. It is, however, necessary to prevent cross-contamination in the dental clinic. But to prevent cross-contamination, more is needed than following the guidelines and infection control protocols only. We need to understand how microorganisms behave under certain conditions. So conclusive, there are several challenges to overcome during this COVID-19 pandemic. Most important is to realize that this virus spreads through droplets, including small aerosols. And these we do produce massively during dental treatment. Lowering the risk is possible by taking appropriate measures, as indicated in this presentation. But you need to realize that we never can bring the risk to zero. There's always a chance for transmission of the virus in such quantity that this will result in a disease. When you are a dental healthcare professional who is vulnerable for such an infection, you should act accordingly. Not necessarily by refraining from work, but be careful what to do and what to ask others to do. I hope this information can help you making your own choices for a safe dental practice. So I wish you all good health. Stay safe.
It's my great pleasure and honor to introduce our guest Martin Exner, who is an outstanding expert on guidelines for infection control in medical settings and dental settings. Since 1994, he is professor and director of the Institute for Hygiene and Public Health at the University of Bonn. Since April 2010, he is president of the German Society for Hospital Hygiene, and for more than 30 years he is member of the Commission for Hospital Hygiene and Infection Prevention at the German Robert Koch Institute, which is Germany's Institute for Public Health. In his scientific career, he thoroughly investigated several aspects related to biofilms in dental units. So my first question is about dentists. They work in proximity to the oral cavity and thus they are exposed to blood, saliva, spatter and aerosol. So how would you rate the infection risk in dental settings for COVID-19?
Yeah, we know as hygienists we have to ask where is the reservoir of a pathogen, how it is transmitted and how it is taken up, how he will infect persons. And concerning COVID-19 or SARS-CoV-2, we know that the reservoir is mouth and nose because there are the receptors by which the virus is entering the human cells. These reservoirs are the workplace for dentists and therefore there is a natural high risk for dentists when they are treating patients who could be infected with COVID-19 or who are shedding SARS-CoV-2.
Is the quantity and quality of virus in the aerosol high enough to induce infection of patients or of dental staff?
It depends from the patient. We know that there are big differences. We know that we have patients who have low concentrations in the saliva by 10 to the 3, 10 to the 4 copies of viruses per milliliter saliva. But there are also patients who have very high concentrations of up to 10 to the 10 copies of viruses per milliliter. But you don't know who is a super spreader, as we call those patients, and who have lower concentration. And if you have such a super spreader, then you must take into account that there is high enough concentrations also to be infected.
In dentistry, we oftentimes use water-cooled systems, so the saliva or the concentration of virus is diluted with the large quantities of water. Is there any knowledge how does this affect the infection risk?
For the moment, I don't can say how it is lowered or not lowered this risk, but we must take into account that it could be a better transmitter because you have droplets which can be loaded by viruses if you have a super spreader who is shedding high concentrations of viruses, and therefore we see it for the moment as an additional risk, not only working in the oral cavity, but when you produced water aerosols, then we see it as an additional risk for dentists.
Okay. And sometimes we have in dentistry a situation that there is not just one patient per room, but there are several dental units in the same treatment room. Does this increase the infection risk from one patient to the other?
This could an additional risk, because we must take into account that you have also an emission of viruses by aerosols in the air. And if you have a very high load also in the aerosol, then we can't exclude a risk for other persons who are in the same room. And because patients can not use masks while they are treated, they are also open to take viruses, to be infected by viruses in the mouth, and therefore we must use every possibility to lower this risk.
So does it make sense to have some walls, small plastic walls between the patients? Would this be an effective measure?
It makes sense. You can also try to use dust to look how the dust is transmitted. You can, for example, also, if you have not such professional methods, you can also use the smoke of cigarettes to see what is happening with the smoke when and how the air is ventilated. But your question, you should have a limit between by a curtain or by a wall between patients.
Another option would be to clean the air. And as far as I know, there are some air filtration appliances available on the market that can be used also in dentistry.
Yeah, we know it, and we have investigated such systems which have integrated a high efficiency particulate filters system, a HEPA filter system, which are very efficient. And we have used bacteriophages, which are viruses, and we can see that these systems are able to reduce the concentrations in the entrance of the system up to 6 log steps. It means it's from an experimental way, it has a very high efficiency to reduce a virus load. But if you have such systems, you must look if these systems are able to rechange the air in an efficient way, and therefore it depends from the size of the room and other aspects, and therefore you must try to find a good way together with specialists, for example, from the enterprise which produce these filter systems.
And are these filter systems more effective than natural air ventilation?
They have a good efficacy, and what we know is that you can use up to 3 to 6 exchanges of the air in your room. It depends from the size of the room, but therefore this is really an option to lower the risks by aerosols in dentistry. praxis.
Would you recommend them for dentists, especially during the winter season? We all know that natural air ventilation is not so easily done when it is cold outside.
I think it's a good option, and therefore we say in every instances where you have no possibility to wear masks, and this is in dentistry practice, because the patient cannot use masks, then you should take into account also these solutions.
And if you only have the option to do air ventilation, how long should you open the windows in summer and in winter? Is there any recommendation on that?
Yeah, we have now recommendations, and we say in wintertime you should open, for example, in school classes where there is the same problem, in wintertime 3 minutes after each hour, to reduce the virus load of the air.
And in summer, would this be longer, or is it the same?
In summer, if you have the possibility, you can open the window so long you want. It depends. If you have a high traffic load outside, then you should then you can open it for 5 to 10 minutes.
Okay, that's very interesting. And if we go back to the automatic filter units, how effective are they? And as far as I know, there are these mobile systems and also fixed systems. Is there a difference between these systems?
In fixed systems, in central ventilation systems, they should use up to 100% fresh air. If this is not possible, because we have in these systems very often a recirculation of air, you should ask how high is the percentage of the recirculated air. In most cases we have up to 60 to 70% recirculated air, and then you should look if you have a filtration system. The ideal way is to use, also in dentistry, HEPA filtration systems, but it's not the normal situation. But if you have a filter, you should have 2 filter systems. For example, F7 and another F9 filter system. It's classification which is old, but you should have 2 filters in your system. But every dentist should look for his technical ventilation system if they have a central ventilation system.
And how often should these HEPA filters be exchanged?
It depends. Normally you have not very high polluted air also in dentistry. It depends on the difference of pressure, and then for example we say that it's 4 to 6 months you should change, but there is no fixed rule. It depends on the pollution of your of the air.
And does it make sense to use a system with an automatic cleanage of the filter?
In mobile systems, they have such thermal treatment. They are the filters are heated up to 100 Celsius, and by this you have no risks, and you can use the filter for a very long time.
Okay. And is there any chance that a virus gets released once it has been captured by the filter?
As we know, there is not very high risks. I can't exclude if you have leakages in the filter that it could be released, but this would you see, because then you have no resistance of the filter systems.
And is there any maximum room size which is applicable to one filter system, or is it more the exchange rate of the air at which we should look?
It depends on the room size. There are rules, and the engineers which are specialized on this can look for it, and can you consult which exchange and which system you should use.
Another option to protect dental staff, dental professionals, is wearing of FFP2 or FFP3 masks and face shields. And oftentimes it's only recommended for aerosol generating procedures. But given the high infection risks of dentists, as we work in close proximity to the oral cavity, and that we actually don't know if a patient is infected because many patients are asymptomatic, would you recommend these masks to every patient, or that they are only worn for aerosol generating procedures?
I would propose it for every patient, because, as you said, you can't see if patients is a shedder of the viruses or a super spreader. And if you have procedures where you have spills of blood, or if you produce by water aerosols, you should use also face shields.
And what type of mask would you recommend? Is FFP2 sufficient, or is FFP3 superior and should be used during pandemic?
FFP3 is has the highest efficiency, but you must have a balance between the comfort of wearing masks and a FFP3 masks you can't use for a very long time, and therefore I would propose to use, if you are working at the oral cavity, to use FFP2 mask.
And how long can I wear such a mask? Is it for a day, 2 days, just a half day?
Just a half day. It depends on the regulation you have, but we say not more than half a day. Then you should change. We have now the situation that we have no problems with enough FFP2 masks, and therefore it should be possible, because you have also, if you are using aerosols or water, then you have the risk that your mask is wet, and by this you could have a lowering of the protection effect of the masks.
And can this risk be reduced by wearing double masks? Means FFP2 mask and one surgical mask above it?
You can do it, and also our colleagues in Bonn, at the University of Bonn, are using this. But they has done it also to protect the mask, to have longer periods or more hours which they can wear the masks.
Can it be then worn for a day, or is there any knowledge on that?
It may be possible, but I would wear it for a half a day, and then I would change it.
Okay. Sometimes there are patients with a high risk for a severe disease progression. And for these patients, does it make sense to treat them at the beginning of the day or at the beginning of a shift?
Yeah, I would say yes, because then the dentist is awakened, he is fit, and he is not tired, and the environment is disinfected, and therefore by these organizational methods you can reduce also the risk for these patients.
Another thing we know is that our water-cooled systems have the so-called reflux. And therefore in Germany it is recommended to rinse these instruments between patients. Would you also recommend this to reduce the virus load during pandemic?
A clear yes. You should use every method to limit the exposition to saliva, and therefore it is a good method to rinse after each patient the water.
Okay. And what about the antiseptics? We know they are effective against bacteria, but does it also make sense to use them to reduce the virus load in saliva?
We have now new publications who are using cell cultures for COVID-19, SARS-CoV-2, and these experiments are just published, and they show that there are some antiseptics who have a very good efficacy to reduce the virus load in 30 seconds in laboratory. But we can translate these recommendations to the in vivo system and for our patients, and therefore we know that some antiseptics are very effective, other antiseptics have no very good results. For example, hydrogen peroxide has, concerning SARS-CoV-2, no good reduction efficacy, but P4P iodine or alcohol like Listerine have a very good efficacy of more than 3 log steps reduction. And therefore, by this you can give the patient an antiseptics just before the treatment to reduce the virus load. You will not have a long-term effect, but for the time of treatment, it could be a good method to reduce the virus load.
Okay, thank you very much for this very interesting interview. One last question. Could you please summarize the key points which will be important for dentists, especially in winter when it will become cold, when we still have the pandemic and even higher number of cases than we have now?
Yeah, COVID-19 is a new challenge, a new infectious disease, and dentists are have a very high risk because they are working at the reservoir of the oral cavity. There is a high risk, and you must take it into account that you, under the medical professions, in the rank of the medical professions, one of the highest risks in your profession. Therefore, you should use every opportunity to reduce the virus load when you are treating the patients, because you never know if the patient could be infected. You must take into account that he could be infected because you have no symptoms. 30% of our patients which are infected have no symptoms. Therefore, you should use every possibility to reduce the virus load by cofferdam, by antiseptics, and you should use to protect yourself and your co-workers masks, which is very, very important. And in high-risk situations, you should also use face shields. And then you should also lower the concentrations of in the aerosols, and therefore you should open, if you have no technical ventilation system, the windows after each patient just in the wintertime for 3 minutes. Then you have a good exchange of the air in your dentistry rooms. And if you have a ventilation system, then you should look how is the exchange of the room. I think you should use 2 to 3 exchange per hour. And if you have no ventilation systems, no possibilities to open windows in your praxis, then there is a possibility to use mobile filter systems, which have HEPA filter systems, and which you can use to lower the concentrations in the aerosols in a very efficient way.
Okay, great. Thank you so much for all the information, and thank you for watching this interview.
I'd like to introduce our next speaker, Katarzyna Gurzawska-Comis from Birmingham. She's currently NIHR academic lecturer in oral surgery, And she was also involved in the COVID-19 testing lab, and she was also providing emergency dental care during the COVID-19 pandemic. She is involved in development of a local guideline on infection control, and in addition, she's also involved in 2 research projects on COVID-19. So Kaja, please, the stage is yours.
Good morning, good afternoon. My name is Kasia Gurzawska-Comis, and I have a pleasure today to present work, Measures to Limit Infection, Current Evidence and Experts' Opinion. COVID-19 started in Wuhan in 2019, and pandemic was declared by WHO in March 2020. Since then, number of medical and dental associations publish guidelines to support the provision of help for our patients. Therefore, our group, composed of dental clinicians, dental scientists, and a lawyer, aimed to create easy-to-apply recommendations from dentists to limit the infection rate in dental settings. The aim of our work was to summarize recommendations for individual risk assessment, patient triage, and measure to prevent health professionals from infection via nosocomital transmission in dental clinics. However, we had additional aim to synthesize the related legal and ethical framework justifying the proposed recommendations. For the individual risk assessment and patient triage, we decided to create the patient questionnaire assessing the epidemiological history and also clinical manifestation of the patients. Then the patients were divided into 3 groups: very high risk, and now no risk, based on the answers from the patients. The very high risk and high risk group was re-evaluated and considered if the treatment can be postponed. The group with unknown risk was then assessed for further treatment, and the treatment was divided into 3 groups: urgent, as soon as possible ASAP, and postpone. And this is one of the examples from London, from Guy's Hospital, a center for COVID, where clinicians divided the treatment into 3 groups following the Scottish guidelines: emergency, urgent, and routine. One of the most controversial topics among clinicians was use of the personal protective equipment in dental clinic. Therefore, our group concentrated on summarizing the scientific evidence on masks, hand hygiene, full body coverage, office measures, and patient's measures. However, I will concentrate today on FFP or FFP2 masks that are the biggest change in our daily practice. So we have number of manufacturers for FFP masks, and FFP stands for filtering face piece and is defined by European standards, and N stands for not resistant to oil and is defined by US government. And the number stands for minimum filtrating efficiency. So FFP2 mask is equal to N95 and FFP3 mask is equal to N99. The WHO recommended to use at least FFP2 mask in dental settings for aerosol generating procedures. Studies also showed that the fit of the mask is crucial. Good and sealed mask, FFP2, protect us from 99.6% of the virus, and the surgical mask, 94.6%. However, poorly fitted FFP2 masks only protect us from 66.4% of the virus. So it's the same as using the normal surgical mask in the clinic. So please be sure that your mask is fitted well when working with patients used with aerosol generating procedures. As an example, a group from London, Guy's Hospital, defined a guide for use of PPE for different dental procedures to minimize the risk of transmission among the dental staff and also patients. So how looks the rest of our body at the moment, how we work in the clinic, and what we do with the rest of our body. So we cover our head with surgical cap. We also cover our eyes with face shield, and also we use surgical gowns in order to protect our body. However, all this protection is not without limitation. The limitations are cost, also comfort of work, and I think the most important is the creation of barrier between dentist and the patient. In my personal opinion, I think this is the most challenging to break this barrier, especially for patients with anxiety and systemic diseases, among which the communication is the most challenging and important to proceed with the success of the treatment. When considering patient measures, we need to think about the waiting area and dental settings. So I would like to show you an example from Birmingham Dental Hospital, where I work at the oral surgery department, how we facilitate the measures. So as you can see, the waiting area has defined spaces for patients to make sure that they keep the 2 meters distance. Also, in areas like lifts, we have signs and limitations of the individuals that they can use. And also, everywhere in hospitals, there are signs reminding us about the social distance and wearing of the face masks. COVID-19 raises ethical and legal issues, including prioritization of medical resources and access to medical care. The 4 principles in medical ethics, autonomy, beneficence, non-maleficence, and justice, may support dentists in making decisions about providing dental care. Dentists have a duty to act in the best interest of the patients and respect their choice, autonomy, and dignity. Unfortunately, COVID threatens the most vulnerable group of patients, elderly, the one with systemic diseases, and from social democratic deprived areas. Therefore, the most important should be to accept the patients for treatment only based on the medical diagnosis. Due to the diverse in recommendations and limited scientific evidence, our group decided to construct another study, a survey among the experts in Europe. And the aim was to collect experiences and recommendations of frontline clinicians on critical aspects of dental treatment provision during pandemic. We received the answers from 27 countries that you can see on the map, out of 32. And the experts highlighted that the transmission risk of SARS-CoV-2 in dental setting for aerosol-generated procedures was high. The other important aspect that they highlighted was the use of PPE, and they recommended to use FFP2 or FFP3 mask, face shield, and also gowns during the AGP's procedure. In conclusion, our studies showed there is a minimal evidence for use of PPE, and further studies are necessary to be constructed in order to recommend and guide the dentist to use the specific personal protective equipment during both non-aerosol generating procedure and aerosol generating procedures in dental settings. Thank you for attention.
Dear Kasia, thank you for the nice presentation. I have 2 questions. And today you introduced several national and international guidelines that have been formulated in the recent month. And I'm wondering, are we at the end of this development process, or is there still a need to further develop and specify the dental guidelines on infection control?
Thank you for the question. It's very important. I think it's very difficult to have uniform guidelines. Therefore, we tried to summarize them in this paper. However, we have to consider that each of the country has different regulations. If every hospital or clinic has different regulations Of course, we need to follow our infection regulation, national one. However, this is a topic that should be further studied because we don't have enough evidence, scientific evidence, on our personal protective equipment, how it protects us from the virus. So I think further studies should be constructed and support providing the care to our patients, but also protecting us and our families from this virus.
And my second question is about the gowns. We've learned that coronavirus is mainly an aerogen transmission, so aerosols and droplets are mostly relevant, whereas contact transmission may not be so relevant for disease transmission. So is there actually a need to use gowns in every dental specialty, including prosthodontics or restorative dentistry? Or is there mainly a need for our surgeons to wear gowns?
It's a good question as well. I can only, of course, speak on behalf of my specialty that for us it's very usual and on daily basis we use gowns and we feel comfortable with them to use them because we protect ourselves from transmission of droplets from the patients. But in case of other clinicians, I think there are regulations for aerosol procedures and they are defined, strictly defined, which is aerosol procedure and which is not. So if the guidelines are saying, yes, this is the aerosol procedure, then we should use the full protection. So the gown, the face shield and the mask and also the cap.
And now we've come to the end of the final session of the EAO Digital Days 2019, and I'd like to thank all the speakers for their excellent presentations today. So what did we learn? We heard that we do not dilute the aerosol with the water that is inside our water-cooled instruments, but instead we are producing an aerosol which may be somehow dangerous for disease transmission in dental settings. Thus, it is very important at the moment that we use proper PPE, and especially there was consensus for aerosol-generating procedures to use FFP2 masks together with a face shield. There seems not to be a need for FFP3 masks, which may be related to further breathing problems and also headaches. And we also do not know at the moment if gowns are really necessary or not, but at the moment they are still recommended to use for our aerosol generating procedures. For aerosol-free procedures, it's very important to consider that we have pre-symptomatic or asymptomatic patients which can have a high virus load in saliva. Thus, there's also some rationale to use FFP2 mask for every patient if it is available. But we should focus on the proper wearing of the FFP2 mask because otherwise they might lose their functioning. Another relevant concept that has been introduced today, which is not a standard at the moment, is air filtration. We have fixed systems and also mobile apparatus with HEPA filters that can eliminate the virus from aerosols. If such an apparatus is not available, we should at least open the windows during the cold season for 3 minutes to ensure natural ventilation. And besides that, we learned that our antiseptics, which we use in dentistry, are also useful against coronavirus, but at the moment we do not know how long the effect may last. And finally today we learned that antigen tests may become an important and interesting perspective for dentists because we can easily identify our high-risk patients before treatment. Now I'd like to thank all our speakers for their excellent presentations today. I think we've learned a lot and hopefully we can apply our new knowledge in the upcoming month. And dear audience, I wish you all the best for the ongoing pandemic. Stay safe and healthy.